Acute appendicitis. Inflammation of the appendix is a significant public health problem, with a lifetime incidence of 8.6% in men and 6.7% in women, with the highest incidence occurring in the second and third decade of life. The etiology of appendicitis is perhaps due to luminal obstruction, that occurs as a result of lymphoid hyperplasia in pediatric populations. In adults, it may be due to fecaliths, fibrosis, foreign bodies, food, parasites, calculi, or neoplasia. Early obstruction leads to bacterial overgrowth of aerobic organisms in the early period, and subsequently, it leads to mixed flora. Obstruction generally leads to increased intraluminal pressure and referred visceral pain to the periumbilical region. It is postulated that this leads to impaired venous drainage, mucosal ischemia leading to bacterial translocation, and subsequent gangrene and intraperitoneal infection. E. coli and Bacteroides fragilis are the most common aerobic and anaerobic bacteria isolated in perforated appendicitis. History. Inflammation of the visceral peritoneum usually progresses to the parietal peritoneum, presenting with migratory pain, which is a classic sign of appendicitis. Inflammation can often result in anorexia, nausea, vomiting, and fever. Regional inflammation can also present with an ileus, diarrhea, small bowel obstruction, and hematuria. Pertinent negative history, including menstrual, must be obtained to rule out other etiologies of abdominal pain. Physical examination. Most patients lay quite still due to parietal peritonitis. Patients are generally warm to the touch with a low-grade fever, and demonstrate focal tenderness with guarding at McBurney's point, which is found 1/3 of the distance between the anterior superior iliac spine and the umbilicus, is often the point of maximal tenderness in a patient with an anatomically normal appendix. Certain physical signs with their respective eponyms can be helpful in discerning the location of the appendix. Rovsing's sign. Pain in the right lower quadrant after release of gentle pressure on left lower quadrant, normal position. Dunphy's sign, which is pain at right lower quadrant during coughing, suggests retrocecal appendix. Obturator sign. Pain with internal rotation of the hip, suggest pelvic appendix. Iliopsoas sign. Pain with flexion of the hip, suggest retrocecal appendix. In addition, pain with rectal or cervical examinations is also suggestive of pelvic appendicitis. Lab findings. Patients with appendicitis usually have leukocytosis of 10,000 cells per cubic millimeter, with a higher leukocytosis associated with gangrenous and perforated appendicitis or around 17,000 cells per cubic millimeter. Features on a CT scan that suggest appendicitis include enlarged lumen and double wall thickness greater than 6 mm, wall thickening greater than 2 mm, periappendiceal fat stranding, appendiceal wall thickening, and/or an appendicolith. Features on an ultrasound that suggest appendicitis include a diameter of greater than 6 mm, pain with compression, presence of an appendicolith, increased echogenicity of the fat, and periappendiceal fluid. An easily compressible appendix less than 5 mm in diameter generally rules out appendicitis. Differential diagnosis: acute mesenteric adenitis, cecal diverticulitis, Meckel's diverticulitis, acute ileitis, Crohn's disease, acute pelvic inflammatory disease, torsion of ovarian cyst or Graafian follicle, and acute gastroenteritis. Management of appendicitis: the preferred approach to manage patients with uncomplicated appendicitis is an appendectomy currently. Conservative management can be offered to informed patients using techniques of shared decision-making, but it is not the standard modality of management of appendicitis, except in patients with significant phobia of surgery. Perforated and gangrenous appendicitis and appendicitis with abscess or phlegmon formation are considered complicated appendicitis. Interval appendectomy. The majority of patients with perforated appendicitis, 80%, have resolution of their symptoms with drainage and antibiotics. There remains debate about the value of performing an interval appendectomy 6 to 8 weeks after the original inflammatory episode. Currently, shared decision-making is necessary before proceeding with an interval appendectomy.